introduce our next speaker, Mr. Novoneel Chakraborty, who will be speaking on the highly relevant topic bias, explainability, and the black box problem of AI, the real risk in clinical research. Mr. Chakraborty is the program manager at the Center of Data for Public Good and Indian Institute of Science, Bangalore, with over 7 years of experience spanning data science, privacy engineering, research, and program management. At IISc, he leads the health tech initiatives focused on health data platforms, anonymization, federated data infrastructure, stakeholder engagement, and policy development. His expertise includes differential privacy, key anonymization, trusted execution environments, privacy preserving machine learning, and secure data infrastructure, all of which are increasingly vital as artificial intelligence becomes integrated into healthcare and clinical research. He has designed and deployed innovative privacy preserving solutions such as SPIDER, a secure de identification pipeline, and scalable key anonymization framework. He has also built machine learning pipelines using technologies such as TensorFlow and Opacus, ensuring that advanced analytics can be performed while protecting the sensitive health data. Before joining IISc, he served as a program manager at Tata Lockheed Martin, coordinating large-scale research and development programs involving multiple stakeholders. He was also selected as Young Leaders in Tech Policy Fellow by the University of Chicago Trust, contributing to the development of privacy-preserving urban infrastructure. Mr. Chakraborty has authored 8 research papers and preprints published in leading venues such as IEE, ACM, and ARXIV. His interdisciplinary background, combining engineering, policy, and responsible AI, makes him uniquely positioned to address the challenges of the transparency, bias, and trust in artificial intelligence. We welcome you, sir, and over to you.
Hello. Thank you very much for that very kind introduction. Please confirm that you can hear me okay, that I'm audible.
Yes, sir, we can hear you. You're audible, sir. Yes.
Okay, I'm just going to present my screen. Okay. So good afternoon, everyone, and thank you very much for the opportunity to speak at this virtual conference. And today I'm going to talk about something that I like to call the algorithmic chasm. So over the last decade, artificial intelligence has moved away from being primarily a research topic to becoming an increasingly visible component of clinical practice. And we're now seeing that AI systems are being used for things like radiology interpretation, tuberculosis screening, risk prediction, pathology workflows, genomics, and clinical decision support. Many of these systems demonstrate an impressive performance in controlled validation studies, but as clinicians and researchers, our responsibility extends beyond just performance metrics, right? We need to understand how these systems arrive at their conclusions, how well they can generalize across different populations, and what risks they may introduce when deployed in real-world healthcare settings. So today I'm going to focus on 3 themes that are related to each other: algorithmic bias, explainability, and the black box nature of modern AI systems. And I'll discuss these topics specifically through the lens of the Indian healthcare and clinical research landscape. But before we discuss some of the challenges associated with clinical AI, I think it's worth acknowledging that these technologies are already producing meaningful clinical benefits in several areas of healthcare. So one of the reasons that AI has generated so much interest in healthcare specifically is that it addresses problems that are particularly relevant in countries such as India, right? We have very large patient populations and significant variation in access to specialist care. And there are substantial differences in the infrastructure that is available between urban and rural settings. So under these conditions, appropriately designed AI systems can function as force multipliers for the healthcare workforce. And Cure AI is a very excellent example of this. So they have developed this platform called QXR, which has been deployed for chest radiograph interpretation. and tuberculosis screening, and emergency radiology workflows. Now, these deployments have demonstrated measurable improvements in detection rates and reductions in reporting delays, particularly in environments that are very resource constrained. And similarly, on the right, Niramai has developed the thermalytics platform for breast cancer screening in India. And this is actually a very thoughtful adaptation of AI, because this system has taken into account cultural considerations. It addresses modesty and stigma barriers because the system is completely non-invasive, radiation-free, and most importantly, contactless. So they've thought about both infrastructure limitations as well as cultural considerations, and that has led to really wide-scale adoption of systems like this. So what's notable about both of these examples is they were developed with a very clear understanding of the clinical and operational environments in which they would be used. And they were localized for their deployment use case, which is they were going to be deployed in India, and Indian considerations were taken into account. So these are two examples that demonstrate that AI can actually create substantial value when the technology, the clinical workflow, and the target population, all three of these things are appropriately aligned. But these successes also highlight a very important question, right? Which is, what happens when the population on which an AI system is trained is very different, is substantially different from the population on which it is ultimately deployed? And that brings me to the idea of bias. So at its core, machine learning is just a pattern recognition process. And an AI model can't understand a disease mechanism in the same way as a clinician. What it does is it identifies statistical relationships within historical data, and then it learns those relationships, and then it applies them to new cases. What this means is that the characteristics of the training data become critical. A very frequently cited example comes from the dermatology field, where you had researchers who were examining publicly available skin cancer data sets, and they surveyed 21 open access skin cancer detection data sets. And these are the data sets that were being used to create melanoma detection models across the world. So they looked at over 1 lakh images from these data sets, 106,950 images. And out of this 1 lakh image data set, only 2,500 images had information about what skin types were actually being represented in those images. And among those, only 10 images were of people with brown skin. And only 1 image was of someone with very dark brown skin. So this creates a very obvious challenge, right? When you apply a model such as this, which has been trained predominantly on fairer colored skin, and you apply it to a population in which darker skin tones are more predominant, it's not going to work. It's not that the algorithm was poorly designed. It's not that. The algorithm learned exactly what it was supposed to, right? It learned from a data set that did not adequately represent the population it was expected to serve. Now, a similar concern has been observed also with pulse oximetry. This is something that became very relevant, especially a few years ago during the pandemic. But several studies have shown that oxygen saturation measurements may be overestimated in individuals with darker skin pigmentation. So when the clinical data already contains such biases that have come from the measurement, that have come from when the data was collected, then the AI systems that are being trained on this data are just going to inherit and amplify those errors. So importantly, representation bias is only one way in which algorithmic bias can emerge, right? Even when the data is accurately collected, the choice of variables that are used within a model can create unintended consequences. And that brings me to the Optum proxy problem. This is considered one of the most, it's one of the most widely discussed examples of bias in healthcare AI, because it illustrates a problem that's very relevant to clinical research. So the people at Optum were designing a model, and the objective of the model was simple. They wanted to identify patients who would benefit from enhanced care management programs. And the challenge was that clinical need is very difficult to quantify. How do you actually quantify clinical need? To do this, the developers used a proxy for clinical need, and that proxy was healthcare expenditure. The idea was, at first glance, reasonable, right? Patients with greater illness burdens often require more healthcare resources. But the problem is that healthcare expenditure reflects much more than just disease severity, right? It also reflects access to healthcare. Patients that are facing socioeconomic or structural barriers to healthcare, they'll have lower healthcare costs, even though they have similar underlying disease burdens. And that's simply because they don't have access to that level of care. So the algorithm interpreted this lower expenditure as a lower need, and consequently, it assigned lower risk scores to patients who actually may have required additional support. So the lesson here sort of extends beyond this particular case study. But the lesson is that whenever we use proxy variables in clinical research, we should carefully consider what those variables truly represent and what hidden assumptions they may contain. When algorithms based on these assumptions are deployed at scale, even very small biases can affect a very large number of patients. So I just want to give you 3 numbers to sort of take away from this talk, right? And these 3 numbers are sort of trying to capture different dimensions of AI-related risks in healthcare. The first is 28%. We spoke about this. This is the increased false negative rate observed in melanoma detection. So because that model was being trained on such a small set of people with brown skin, it was inaccurate 28% more in detecting melanoma. The second is 1.2 seconds. And this is an example from a company called Cigna. They developed a model called PXDX, procedure to diagnosis. And the idea was that they would do automated insurance claim adjudication. But this model spent only 1.2 seconds on every claim. It would just match against a pre-populated table of claims. And if there was a direct match, it would accept, otherwise it would reject. And each of these claims represents a human being, right? And only 1.2 seconds was being spent on every human. And the model denied around 3 lakh claims in 2 months. The third is 90%. And you'd think 90% refers to the accuracy of some AI model, but in this case, it actually refers to the reported error rate. So there is a system called NH-Predict, which is used in litigation documents. And the NH-Predict algorithm was known to the developers to have an error rate of 90%, but it was still deployed to 2 million plus patients who were receiving Medicare in the US. So they knew about the pitfalls of this algorithm, but they still deployed it. So these 3 examples are substantially different in terms of technology, clinical context, and intended purpose, but they have one common theme, right? In each case, the algorithmic outputs influence decisions at a scale that you would not have been able to achieve through manual processes alone. And this is one of the defining characteristics of AI in healthcare. The benefits for AI in healthcare scale very rapidly, but unfortunately, the errors can scale just as rapidly. So to understand why these errors occur, I think it's useful to examine what modern machine learning systems are actually learning. So clinicians often assume that an AI system learns the same diagnostic features that an experienced physician would use. But this assumption is not always correct, right? researchers at Stanford did an investigation using generative counterfactual analysis on a dermatology classifier. And they did this to better understand what features were driving model predictions. And some of the expected features were present. The models paid attention to things like pigmentation patterns, asymmetry, and lesion characteristics. However, they also relied on features that clinicians would not consider biologically meaningful, such as body hair, which was present in the biopsied melanomas. It just so happened to be there in the images, and ruler markings that were in the image. Because if a lesion was particularly large, there was more likely to be a scale or a ruler present in the image, to sort of capture how big it is. And artifacts from the biopsy, scars, and so on, and characteristics of the device that was used to image the melanoma. And these features are not causally related to melanoma itself. They just happen to be correlated with melanoma in the training data set. This is what the model was actually learning. Right? So this phenomenon is often referred to as shortcut learning. The model achieves really good predictive performance, but it does so by exploiting correlations rather than learning any clinically meaningful representations of disease. So once we recognize that these systems may rely on unexpected features, the natural question becomes whether explainability methods can help us understand and evaluate the reasoning. So when clinicians encounter a black box like the one we talked about in the last slide, the natural response is, can you explain why the model made this prediction, right? And this led to the development of AI-based explainability approaches such as SHAP and LIME. Now, these tools are useful, but we must understand their limitations. Both of these explain how the model combines variables, and they don't explain disease biology in any way. For example, suppose a model concludes that older patients have a lower kidney disease risk. Right? Older patients have a lower kidney disease risk. Just hypothetically, assume that a model makes that conclusion. In that case, SHAP might identify age as a predictive factor against kidney disease risk. But clinically, any clinician or any researcher would know that that conclusion makes no sense, right? So the explanation might actually reflect survivor bias in the data set rather than true biology. And I think this is a very critical distinction. Correlation is not the same as causation. And an explanation of what the model is doing, which is what SHAP and LIME are trying to do, is not necessarily an explanation of reality. So when evaluating AI, we should always ask, am I seeing a biological explanation or am I seeing a mathematical explanation? So this slide, I think, is very important for a country like ours, right? South Asians, which includes India, Pakistan, Sri Lanka, Bhutan, Bangladesh, and Nepal, we represent approximately 1/4 of the entire global population, 1/4 of humanity. Yet in global genomics research data sets like GWAS, we account for less than 2% of that data, which means that many precision medicine tools are trained primarily on European populations. So the government of India started the Genome India project to address that very gap. So the Genome India project sequenced around 10,000 genomes. And in that genome sequencing, researchers identified hundreds of millions of variants, including around 7 million variants that were completely absent from any global database. So this has some direct clinical implications, right? Genes that influence responses to drugs like warfarin and clopidogrel, genes such as CYP, 2C9, and so on, their allele frequencies vary very substantially across Indian populations. And India is not one genetic population either. We have more than 4,500 endogamous communities. But in most international databases, we are simply classified as South Asian. And this sort of generalization or aggregation can hide very clinically meaningful differences. So if an AI system has never actually seen your population and never been trained on your population, you should be very cautious about trusting what predictions it is actually making. The good news is that India already has a very strong ethical framework for how AI should be adopted and used in practice. The ICMR ethical guidelines provide 6 core principles that should be followed in adoption of healthcare AI. And those are autonomy, safety, transparency, accountability, inclusiveness, and sustainability. But I want to focus on just autonomy. And the autonomy core principle focuses on including a human in the loop. It makes a human in the loop mandatory for decision making. And what that actually means is that the clinician remains accountable. The AI is just an assistant. It does not make any decisions. The clinician at the end of the day has to be liable and accountable for what decision is being made by the AI. And they are the ones who are implementing that decision. So the AI assists, but it doesn't decide. Similarly, the DPDP Act also has another layer of regulation through consent and patient rights, but some important questions remain unresolved. Like, who exactly is responsible when an AI recommendation contributes to harm? Is it the developer? Is it the clinician? How do we define informed consent for machine learning systems? And how can we audit models that are changing every day? Every day there's an updated model that's being coming out. How can we continuously update our auditing processes to account for updates to models? So these are challenges that not only India, but every healthcare system across the world is currently grappling with. And regulation can reduce the risk, but regulation alone cannot create trust. And ultimately, that trust has to be earned through evidence. So I'd like to end with a practical framework that clinicians and researchers can use when evaluating any AI system. So when someone presents an AI solution to your hospital, your department, or your research group, I would encourage you to ask 4 questions. 1, was it validated on populations similar to ours? 2, has it undergone bias auditing? 3, can the reasoning be examined and challenged? Can we evaluate why the AI is making a specific decision? And 4, does a human actually remain accountable for the final decision? And if the answer to any of these questions is unclear, then it is important to use caution. But if the answers are convincing, as we saw in the 2 success stories that I presented in the second slide, then AI can become a very powerful clinical partner. So I'd like to finish with just one thought, which is the future of medicine is not clinicians versus AI. It's not, I don't see it as a competition in that sense. But the future of medicine belongs to clinicians and researchers who understand AI well enough to know when it should be trusted and when it shouldn't, and who understand the guidelines and the frameworks around how AI systems are developed, and who understand why AI systems fail. Thank you. That brings me to the end of my talk. I'll take any questions.
Thank you, sir, for the enlightening session. We are open to